Hi and welcome back to my channel. I hope that everybody is doing well. I know that it's been a little bit since I've been on here. I'll be totally honest. Between managing work and mom life, it gets a little hectic and very tricky to do anything else. But I really enjoy making these videos, so I'm trying to make it a priority. Just bear with me, guys. I know that I'm not very consistent in making content, but just know that I really want to be. But yeah, life is tricky. It's hard to juggle everything. And so yeah, so here I am. For today's presentation, it's a little different than the usual discussions that I've done, in that usually I focus on one body system or one disease process, whereas this presentation is really focused on all about identifying emergent situations that require urgent action from you. So whether it be an urgent referral to a specialist of some sort or an urgent referral to the emergency department. And these questions, they undoubtedly will pop up on your exam. Remember that your board's exam is created in a way to basically analyze your ability to be a safe novice NP. You can't know everything all the time, but they want to know that you can be safe when you enter into practice. And a huge part of that is being able to identify emergent situations. So these questions are on your exam, I promise you that, and they do happen in practice. So you have to be able to safely identify those and know how to initially manage them. And keep that in mind too, that this presentation isn't meant to be comprehensive and that it goes over pathophysiology and all the other jazz. It's really just focusing on identifying these red flag symptoms and the initial management. So that is what we're going to be talking about now. I hope that you guys enjoy. Don't forget, if you have any questions, go ahead and leave them down below. Don't forget to join the Facebook group. There are so many awesome resources on there. The link is always in the description. Oh, and real quick side note, I've also started a new Instagram specifically for the new NP, so I'll link it down below as well. I want to share like little content on there. If I don't have the time to get on and make a whole video, it might be easier to just share small bits of content on that platform as well. So go ahead and follow that, you guys. All right, now on to identifying warning signs on boards, exam, and in practice. I tried to set this up in a way that makes sense, sort of starting with emergencies from the head and then moving down the body. Of course, remember, this is not meant to be comprehensive and cover all possible emergencies. That would be a very long video, but instead I focus on more common emergencies that appear on your board's exam. So first up is angioedema. Angioedema generally affects the skin and mucosal tissues of the face, including the lips and mouth, and it can also affect the throat and the larynx. So it's clear that this can be a life-threatening emergency, as it can cause an airway obstruction. So there are two main types. The first one is the mast cell mediated, for example, when angioedema is associated with an allergic response. And then the bradykinin mediated, for example, when angioedema is associated with the use of ACE inhibitors. Either way, if a patient comes in looking like this to an outpatient setting, I think it's an obvious transfer to the emergency department. If it is determined to be allergic-related angioedema, then the angioedema will respond to epinephrine. More mild cases may benefit from antihistamines and glucocorticoids alone. Next up is herpes zoster ophthalmicus. So herpes zoster, or shingles, is a painful unilateral vesicular eruption which generally follows dermatomes. So herpes zoster ophthalmicus, this affects the fifth cranial nerve, and it's potentially sight threatening. So patients can actually lose their vision in the affected eye. And you can see here, this patient's vesicular rash follows that dermatome over the eye and onto the scalp. So early diagnosis and treatment of this is critical in preventing progressive corneal involvement and potential, like I said, loss of vision. You treat these patients with antiviral therapy, including acyclovir or valcyclovir, topical steroid drops to decrease the inflammatory response, and an emergent follow-up with ophthalmology. Hypertension carries many different associated risks with it, one of which is ocular disease, most commonly diabetic retinopathy. So there are some red flags and keywords to look out for when identifying these microvascular changes that can occur to the eye, and they are rated from mild to severe. So mild, you may see something called AV nicking. Moderate is flame hemorrhages and wool spots. Severe microvascular changes includes all of the above plus papilledema. And this actually requires an ER referral for emergent lowering of the patient's blood pressure. This is an emergency and can indicate increased cranial pressure. All right, so headaches. These can be tricky because they're such a common complaint, and you need to know when to have a further evaluation. So these are symptoms not to miss with headaches and keywords to look out for on your board's exam. So the first example being the first or worst headache, that is a red flag. A new headache in patient greater than 50 years old without a history of headaches, that is a red flag as well. If the patient also has a systemic illness, that's a red flag. Headache with exertion, so if they sneeze or cough and they have the worst headache they've ever had, that is concerning. Also, patients that have focal neurologic signs as well, that is a very concerning red flag with headache. And all of these would indicate a transfer to the emergency department to essentially have neuroimaging done of the head that is not available outpatient, for example, like a CAT scan. All right, so along the same line is temporal arteritis, also sometimes referred to as giant cell arteritis. These patients present with a new onset of a unilateral headache, temporal pain or throbbing, and abrupt, often transient visual changes. They may also report things like jaw pain, fatigue, fever, and other systemic symptoms as well. If this is suspected, then you need to initiate steroids immediately and refer them for an emergent temporal artery biopsy, as this remains the gold standard for diagnosis. All right, so obviously very briefly, we will discuss acute coronary syndrome or ACS. So ACS includes a non-ST elevation MI, a ST elevation MI, and then unstable angina. Unstable angina includes new onset chest pain that limits physical activity, angina that has changed, for example, it lasts longer than usual or occurs with less exertion than the patient is used to, or angina at rest for more than 20 minutes. Symptoms of a myocardial infarction or MI include retrosternal chest pain. This is pain that occurs within the chest, and it can radiate down the left arm as well. These are the classic symptoms of an MI, but it's also important to note that there may be other signs associated with it as well, specifically women, as they can present in pretty bizarre ways. For example, they may have jaw pain and unexplained fatigue as they're presenting symptoms for a heart attack. So if an MI is suspected, then administer oxygen if it's needed for the patient, have them chew aspirin, and urgently transfer them to the ER. All right, so next up is respiratory distress. Being able to identify signs of respiratory distress is obviously very important, and symptoms of this include tachypnea, hypoxia, intercostal retractions, accessory muscle use, and even cyanosis. There are many different possible causes for respiratory distress. However, this part is just focused on two potentially severe complications that are specific to the pediatric population, including croup and epiglottis. And I chose these because I saw both of these topics on my board's exam. And also both can lead to respiratory distress and even respiratory failure. So severe croup in pediatrics, they'll present with signs of significant stridor at rest, intercostal retractions, and they may appear very anxious and even fatigued. These patients should be referred to the ER by ambulance, and while they're waiting for the ambulance to arrive, really important to keep the patient calm, as if they are upset and crying, this can actually worsen their symptoms. Give them oxygen via nasal cannula or by mask, whichever they will tolerate more. And then also nebulized epinephrine and oral dexamethasone can be given while awaiting that transfer. Epiglottitis is inflammation of the epiglottis. Symptoms usually begin with fever and labored breathing that can rapidly progress to respiratory distress. Patients may have symptoms like drooling, dysphagia, and distress, and these are the three hallmark Ds of epiglottitis. Emergent transfer to the emergency department by ambulance is indicated here, and the literature even says not to attempt to visualize the throat without actually having intubation equipment ready and available. So that's how serious this is. An ectopic pregnancy is an extrauterine pregnancy, 96% of which occur in one of the fallopian tubes. Abdominal pain and or vaginal bleeding are the most common symptoms of an ectopic pregnancy, and they should be high on your differential with any reproductive age women with these symptoms. Patients with an ectopic pregnancy can become hemodynamically unstable very quickly if a rupture occurs. Symptoms of a ruptured ectopic pregnancy include sudden and severe abdominal pain, feelings of faintness, hypotension, and tachycardia. If any of these symptoms are present or you suspect an ectopic pregnancy or a ruptured ectopic pregnancy, emergent referral to the emergency room is necessary because this requires a surgical repair and is life-threatening. All right, so preeclampsia is another pregnancy-related potential emergency. So this generally occurs at 34 weeks gestation or greater, and it has a triad of symptoms of new onset hypertension, proteinuria, and edema after 20 weeks gestation. Other symptoms of this can include headache and blurred vision. The major concern here is that this can actually lead to eclampsia or seizures and even potentially fetal and maternal death. So this is truly an emergency, and it actually requires emergent delivery of the placenta and the fetus. This is the only cure. So next up is an acute abdomen. This is another potentially tricky chief complaint, as a lot can be going on with abdominal pain, and it could be anything from gas to AMI. So to help narrow down your differential and who needs to be referred to a higher level of care, there are some symptoms that you should be on the lookout for. For example, patients with unstable vital signs. This is a huge red flag. Also, signs of inflammation on exam, for example, rebound tenderness, guarding, and rigidity. Also, patients with signs of systemic infection, for example, fever and jaundice, can be big red flags as well. Lastly, there's something called the Cullen's sign, and this is bruising around the periumbilicus, and this can actually indicate hemorrhagic pancreatitis, so this is also a big red flag. Intussusception causes severe and sudden abdominal pain and is a medical emergency. It occurs most often in young children and is when the intestine telescopes in on itself. So symptoms include intermittent colicky abdominal pain. With infants, sudden, loud, very high-pitched crying can be heard that comes and goes with that intermittent pain. Also, current jelly or bloody stools can be seen, and sometimes a sausage-shaped mass can be palpated in the right upper quadrant. This requires an urgent transfer to the ER, again, as this is a medical emergency. Testicular torsion is a urologic emergency, and it's more common in neonates, which are 4 weeks and younger, and post-pubescent boys than adult males. However, it can occur at any age. Testicular torsion occurs from twisting of the spermatic cord, and it can cause sudden and severe unilateral scrotal pain that's also enlarged and erythematous. Also, important tools in the diagnosis of this include patients will have an absent cremasteric reflex and a negative Pren sign. A Pren sign is the relief of pain upon the elevation of the scrotum. In patients with testicular torsion, this is negative because they do not experience relief from pain with the movement. If they did, however, experience relief, then this may indicate that the patient has epididymitis. All right, last up is going to be Cauda-Equina syndrome. And though this is a rare disorder, it is a surgical emergency and a topic I'm sure you'll see a question on your board's exam. So Cauda-Equina syndrome occurs from compression on the spinal nerve roots, and it can cause symptoms of lower back pain, bowel or bladder incontinence, and even saddle anesthesia. If your patient has any of these symptoms, then they should have an urgent transfer to the emergency room where they need an MRI and possible surgical intervention in hopes of preventing permanent dysfunction and or paralysis. All right, that's going to be it for today's discussion. Hopefully you guys feel like you learned a little something. Don't forget to leave me any comments or questions, and don't forget to support the channel by subscribing. I really do appreciate all the support. You guys are amazing. And until next time, I wish you the very best. I'll talk with you soon.